Hey everyone, it's Morgan again, here to talk about my third lecture, which is benign prostatic hyperplasia, or BPH. So what is BPH? So BPH is when we have enlargement of the prostate gland, and this can cause difficulty urinating. It's due to overproliferation, but it's not a malignant disease, unlike prostate cancer. It's a common problem with older men, and the prevalence can vary based on age. So we don't see it as frequently in patients who are 30 to 40 years of age. We see it more frequently in 50 to 60 years of age, and then even more in patients who are over 80. So this is a risk that will increase over time as males age. For the pathophysiology, some things that can play a role include older age, and then also the Leydig cells in the testes, which if you have listened to the androgen and anti-androgen lecture, we talk a little bit more about what those Leydig cells are responsible for. But they will cause proliferation of cells in the stromal tissue and the glandular components. So if we look here at this diagram here, we have the normal prostate compared with an enlarged prostate. So the prostate is located below the bladder, and then the urethra will travel through the prostate to the external area. So with that, we have an enlarged prostate on this side that's causing some obstruction and compression on the urethra there. So that's why we have difficulty urinating in BPH, but then also difficulty completely emptying the bladder. So just as a reminder, some things that play a role in this are the androgens, so testosterone and that mechanism to break down via the 5-alpha to the dihydrotestosterone, or the DHT. So clinical presentation, patients can present with either storage or voiding symptoms. So storage symptoms being that they have frequency throughout the day, but then are also needing to urinate throughout the night. They have some urgency and incontinence, incomplete bladder emptying, and then also some voiding symptoms, such as they have a weak stream, they're stopping and starting while voiding, so they aren't able to continue voiding throughout the entire urination process, but then also they're straining to urinate. So it's a presumptive diagnosis really that's based off of symptoms, but we can also perform prostate exams to determine the size of the prostate and the consistency, and then also some labs can be involved, some things like a urinalysis, looking at their creatinine, and then also prostate-specific antigen, or PSA. So this could be some ways that we either differentiate the diagnosis to something else or determine BPH. So some treatment options are going to include some behavioral interventions, or just to kind of watch the process of BPH and see if it improves over time. So the watch and wait method. Medical management, which can be based on the symptom severity, whether we need to do that or not. And we can also use a score provided by the American Urological Association, or AUA, or the International Prostate Symptom Score. There are some minimally invasive therapies, but there are also some surgical therapies that can be involved in treatment and relief of BPH. So some behavioral interventions can be things like avoid drinking excess fluids before bed if they're having some nocturia. Caffeine and alcohol can also increase the need to urinate, so avoiding those agents or reducing those. Double void, where they actually will urinate twice to release all that is located within the bladder. And then we have our medication treatments. So as I mentioned, that process of breaking down testosterone to dihydrotestosterone, we would use the 5-alpha reductase. So we can use the 5-alpha reductase inhibitors, also the alpha-1 adrenergic antagonist, anticholinergic agents, once again, which we talked about with incontinence, the incontinence lecture, and then phosphodiesterase 5 or PDE5 inhibitors, which would be familiar from the erectile dysfunction lecture if you've listened to that. So the alpha-1 adrenergic antagonist will block norepinephrine and epinephrine effects at alpha-1. So this is located in the prostate and the bladder neck. This will promote relaxation of the smooth muscle of the prostate, improve urination flow, and the effect is almost immediate, which, if you'll remember, we haven't really seen the effects be immediate with some of the agents that we've discussed in the various lectures. So anything that has an immediate effect can be very beneficial to patients who are having increased symptoms related to their condition, so such as BPH in this case. So these include doxazosin, terazosin, alfuzosin, and tamsulosin, and they are all about equally effective, but they may have some varying adverse effect profiles. So looking at those adverse effect profiles and the different dosing, these are each going to be dosed daily and may have some ranges of dosing depending on if that dose needs to be escalated, for example, if it's not doing the job correctly. With terazosin and doxazosin, we do have a risk of orthostatic hypotension, especially if we have the PDE5 inhibitors. There's also a risk of dizziness, fatigue, and then floppy iris syndrome. For the clinical pearls, these do have dose-dependent effects, which is why sometimes we may want to escalate the dose. And if the doses are missed for several days, we'll want to restart at a low dose and titrate back to effect. Taking these at night is recommended. Alfuzosin may have some dizziness, upper respiratory infection, and fatigue associated with it. There is an extended release formulation. It's important to take after the same meal, so at the same time each day. And then it is selective for the alpha-1 receptors in the bladder and the prostate, so there aren't as many off-target side effects with this since it is more specific. Tamsulosin can cause dizziness, a headache, rhinitis, but then also abnormal ejaculation. This one is also important to take after the same meal each day and is also selective for the alpha-1 receptors in the bladder and prostate. So the 5-alpha reductase inhibitors, so this should look pretty familiar. So we have our testosterone that's broken down via the 5-alpha reductase to the 5-alpha dihydrotestosterone or DHT. These are going to be used in combination with an alpha adrenergic antagonist, and they'll inhibit that 5-alpha reductase to reduce the size of the prostate gland because some of the effects of the DHT include the increased BPH. And then this is going to help to improve the urinary flow, but may take a while for effect versus our alpha adrenergic, which were pretty quick to act. So could be good in combination to have something that's going to be able to relieve a patient's symptoms immediately versus something that may take some time but could be good for long-term use, for example. And it can be indicated if a patient has an enlarged prostate, so having greater than 30 milliliters on imaging, if they have a palpable prostate on digital rectal exam, or a PSA that is greater than or equal to 1.5. So finasteride is one of the agents, so it's just at 5 milligrams daily and can be continued indefinitely. If this agent is discontinued, that may lead to relapsing symptoms, so there may be kind of a rebound effect with this. It may help with any hematuria that may be associated. And then some adverse drug effects that can occur include sexual dysfunction, some breast tenderness, and then also PSA lab interference. So those may not be as accurate when the patient's on finasteride. The other thing is that women should not handle this medication, especially if they're pregnant or planning to become pregnant. And then we can also use dutasteride 0.5 milligrams by mouth daily, and that's going to have a similar side effect profile to finasteride. So these range pretty, depending on the product, pretty similar in range. Finasteride is slightly cheaper than dutasteride. We also have anticholinergic therapies, so these can be used for patients with overactive bladder symptoms like frequency, urgency, or incontinence, and these can also be used in combination with the alpha-1 adrenergic antagonist. So these are mentioned throughout the incontinence presentation, so if you want to refer to that lecture, we will discuss those more in detail. And then finally, we have the phosphodiesterase 5 inhibitors, or the PDE5 inhibitors. So these are also used in erectile dysfunction, but the dosing can be different. So this agent is tadalafil, which is Cialis. So the dosing is different because for the BPH, we'd actually use this agent daily versus erectile dysfunction. It's going to be more of an as-needed dosing. The common adverse effects include headache, nasopharyngitis, and back pain. And these should not be combined with the alpha-1 antagonist or the 5-alpha reductase inhibitor due to just no benefit that's been seen with the combination. It is contraindicated with nitrates, so anyone who has nitroglycerin for potential chest pain, and this is because it can cause hypotension with the addition of the two agents. So the erectile dysfunction lecture will have a lot more detail on these agents if you want to refer to that for some more information. And then we have our beta-3 agonist. So these are used for patients with symptoms related to overactive bladder, such as the frequency, urgency, or incontinence. And they're good for patients who aren't candidates for anticholinergics due to some of those side effects or contraindications. These are not to be used alone and should be combined with the alpha-1 antagonist. And what it does is it actually activates beta-3 adrenergic receptors in the bladder. And so this helps to relax that detrusor smooth muscle to increase the bladder capacity. So the example of this one is mirabegron or mirabetril. This one was also discussed in the incontinence lecture, so it may sound a little bit familiar. But the onset for this one is 8 weeks, so this one also takes a little bit of time to work. It's a little more expensive than some of the other agents that we've looked at today, so it's about $17 per tablet. The adverse events include hypertension that can be related to the dose, and then there are some extended release components, but the granules in the tablets are not interchangeable with that. And then another related product is vibegron, which is Gemtesa. So this is an off-label use for that, and it's pretty similar pricing to the mirabetril, but the adverse event that we could see a lot with the vibegron is a headache. So that wraps up our conversation on benign prostatic hyperplasia, or BPH. Thank you all for listening in.